Hello, and welcome to our online webinar regarding knee osteoarthritis. First of all, who am I? I'm Bob Scanlon, a licensed physical therapist currently practicing with the Village Family Clinic in Hackettstown, New Jersey. I'm a graduate of Northeastern University's physical therapy program. I have over 30 years of outpatient orthopedic care, and I am credentialed in mechanical diagnosis and treatment by the McKenzie Institute USA. So when we're discussing osteoarthritis, some of the things we want to keep in mind is what does it matter to you? Do you have this condition? Have you been told you have this condition? What have you heard about knee arthritis? What advice have you been given? For instance, friends, family members, other healthcare professionals, what have they told you can do about this condition? What have you, friends or family members, tried for the condition, and how successful have you been with these other types of treatments? And how has it affected your daily life? Are you able to do a lot of the activities you'd like to do, or are you having pain or difficulty with these activities? The prevalence of knee osteoarthritis in the United States is about 8% of adults at any given time have this condition, or over 20 million people. Women have a higher prevalence than men, and some of the studies indicate that women may have as high as a 19% prevalence rate, particularly women above age 50, which means basically about 1 in every 5 women that come into a medical office complaining of knee pain may have knee osteoarthritis as an underlying problem. The end result is this is we end up doing 700,000 knee replacements in the U.S. annually, and this number is projected to increase to 3.5 million procedures by 2030. We're discussing knee osteoarthritis or knee anatomy. Some of the things we want to look at are the large muscle in the front of the leg, the quadricep muscle. The reason we want to look at this is this muscle is not only important in moving the knee, but it's really, really, really important in taking shock away from the knee and hip joints. So weakened quadricep muscle group can affect the amount of load that's coming into the knee joint, and in fact also the hip joint as well. In the knee joint area, for instance, if we're developing early to mid-stage knee osteoarthritis and having some issues with this knee, a lot of times weakness of that quadricep muscle will kind of enhance the effect of the knee osteoarthritis because now the knee is taking more force on an already irritated tissue. Knee osteoarthritis itself affects chiefly what's called the hyaline cartilage of the knee. This is specialized joint cartilages at the end of every long bone in your body. This cartilage is made up of a matrix of very, very, very specific types of cartilage cells that allow for almost frictionless type movement between the joints. And as this disease progresses, what happens, we start to see wear and tear and inflammation of this surface region. There's another major structure in the knee as well, known as the meniscus. These are fibrocartilage type entities. They're a crescent shape, and what they help to do is distribute load across the knee. So sometimes early damage from trauma or sport activity to the meniscus can sometimes bring on or accelerate the knee osteoarthritis condition. So again, knee osteoarthritis mainly affects the hyaline cartilage of the knee. And what happens is as this starts to move on, what we start to see is wear and tear of this knee cartilage, as well as inflammation of the cartilage itself. So what can happen sometimes is the knee might be stiff, sore, mildly painful from time to time with activity, and all of a sudden somebody can have a major flare-up or an inflammatory onset within the cartilage of the knee, resulting in increased pain and swelling and more functional loss and difficulty. As the disease progresses, what can happen is we start to get breakthrough in certain areas of this knee hyaline cartilage, and we start to get a bone-on-bone effect, which can become very painful, particularly in certain types of activities. If this becomes extensive enough, generally what's left as an only treatment for this is some type of joint replacement. What are the risk factors for knee osteoarthritis? Age, as we get older, there's more essentially breakdown of this type of tissue that's already started. Generally, most knee osteoarthritis starts anywhere from as early as age 35 up to about as late as age 60. We already discussed this. Female gender has a higher prevalence of knee osteoarthritis. Previous knee injuries. So again, if you've had injury to the meniscus or things like anterior cruciate ligament injuries or fractures in the knee, there's a higher chance of developing knee osteoarthritis or a more advanced level of knee osteoarthritis. And if there's a strong family history as well. Now, these risk factors are not modifiable, but however, there's a couple that we can modify to help reduce some of the pain and functional problems we see with this condition. One is weight. For instance, being overweight is certainly a factor in regards to accelerating the osteoarthritis. The Framingham knee study showed women who reduced their weight by an average of 11.2 pounds, or about 10 pounds on average, reduced their risk of developing OA later in life by as much as 50%. Muscle weakness, again, the quadriceps is really, really important in reducing shock and load around the knee joint. So a healthy, strong quadricep muscle can really help to reduce some of the pain and discomfort that we see with this condition. Other studies have shown that low intake and low serum levels of vitamin D also to have an association with increased risk of knee osteoarthritis and the progression of the disease as well. And interestingly enough, a study that I just happened to look at this morning indicates that good adherence to the Mediterranean diet actually seems to help decrease the chance of developing knee osteoarthritis and maintaining a healthier cartilage structure. Another factor we look at is sedentary lifestyles. And this was an interesting study that came out of the proceedings of the National Academy of Science in 2017. What they noted was that there's almost a doubling of the prevalence of knee osteoarthritis since the mid-20th century. Basically, what we're saying here is pre- and post-industrial ages. Before the industrial age, most people were much more active throughout their day, hence loading their joints and loading their muscle tissue to a much higher degree. We've come along now where we don't really walk to the store much anymore. We drive. We sit all day at work and don't really put a lot of weight or move about as much as we did in the past. And what they found here were individuals who loaded their joints less actually developed thinner layers of hyaline cartilage. So already what we're seeing there is there's already a sort of a setup for this osteoarthritis to wear quicker, since the cartilage itself was no longer as thick. Also, lower proteoglycan content. Proteoglycan is a protein that helps with sort of keeping the healthiness of the joint, and as well as weaker muscles, which are responsible for stabilizing and limiting joint reaction forces, which we discussed earlier in regards to the quadriceps. So sedentary lifestyle is also a factor, and this is why it is important, as we'll discuss later, why exercise becomes an important factor in controlling this process. How's it diagnosed? For the most part, X-ray is used to start the initial diagnosis, but we'll see as we go on, it not only X-ray can tell us, well, the joint's having a problem, the joint's starting to develop some knee osteoarthritis, but it sometimes doesn't tell us the whole story of what's going on with this individual, and doesn't doom the individual to say that they must have a knee replacement. Generally, it's graded from grade 1 all the way out to grade 4, and you can see as it moves along the grading lines, we start to see lessening of the joint space between the two long bones. Eventually, what we get when we get to grade 4 is there's very little space left. We see bone-on-bone contact, as well as the knee sometimes can become deformed or shifted a little bit. You'll see people with extreme either bow-leggedness or their knee sort of bowing inward when they've generally reached this stage. Generally, when we've reached this stage, we really have to start thinking about or considering knee replacement, but not always. One of the issues we have with things like X-rays and MRIs is that when we look at X-rays or MRIs from groups of people who do not report knee pain, we see a lot of the same changes that tend to indicate things like knee osteoarthritis in these non-painful groups. So the problem we have sometimes is someone shows up to an office complaining of sudden onset of knee pain. If they're generally older than 55 years of age, there's a high likelihood that if you do an X-ray or MRI in this individual, they're going to show problems within the knee. And the next question becomes, is that problem in the knee the reason for their pain, or is something else going on? So again, this was taken from the Framingham knee study, 710 patients. And what they did is they did an MRI in the entire group. And what they look for are the types of sort of lesions and problems that you'll typically see with knee osteoarthritis. The blue line represents the group that reported knee pain, and the green line is a group of these patients who reported no knee pain. And what you'll see is the prevalence of these conditions is almost exactly the same whether the person is reporting knee pain or not. Another thing that we can use in regards to seeing how the patient is doing is what we call patient-reported functional tools. There's many out there. The two main ones that you'll see used in most offices are the Knee Injury Osteoarthritis Outcome Score, or COAS, or COOS, Lower Extremity Functional Scale. And we'll post some links to these on the same page as this webinar. So if you'd like to go in and fill out this sheet, it's a great way to see how you're doing functionally, but also tracking how the disease process is going. And for instance, if you're under treatment for whatever reason, or whatever type of treatment, it's a way to see what the effect of that treatment is on your overall function. The one I like to use a lot too is what can't the patient do and what would they like to do? Everybody has a little different approach to how they want to do things. Some people want to simply be able to walk maybe a mile or two. Some people want to be able to return to running, playing tennis or golf. So we need to discuss with the patient sort of what can we do to help them modify or get back to this level of activity. Again, since we discussed this in regards to X-ray and MRI, one of the other things we want to make sure is the source of the pain is actually coming from the knee. In the lower extremity, a lot of times the spine can sort of mimic some of the same knee pain type issues that a knee injury itself will sort of bring out. We have the two main nerves in the lower leg, the sciatic nerve and the femoral nerve, and these can reflect pain down the leg and sometimes give us a thought of a possible knee problem that actually is coming from the back. Another area that needs to be looked at and screened as well is the hip. Usually hip pain tends to be in the front of the leg, a little bit above the knee joint, but you'll see in a moment one of the studies that was done shows that this is not always the case. So one of the things we need to do is when somebody comes in describing a sudden onset of knee pain, particularly without any history of fall or trauma, we want to make sure that we clear the spine and hip as a possible source of their pain, not just the knee. For instance, here, if we look at the pattern of pain that come from a lumbar nerve root irritation or compression, you can see here that in several cases, we can have pain along the outside of the thigh or outside of the knee, directly in front of the thigh, extending down and over the knee and in and around the base of the knee, or just above or almost at the knee as well. And sometimes what can happen is a person comes in, they're complaining of knee pain, they undergo an X-ray, they start to show some moderate knee arthritis issues. They undergo care for the knee and have no results because all along this problem has been coming from their low back. Same thing can occur also with the hip. This was a study where a group of healthy volunteers with no prior history of hip pain underwent injection to evoke pain in their hip. The question here is, where did this pain go when the area was injected? And we see most of the pain stays along the outside or lateral aspect of the hip, as well as into the buttock. But there's a fair amount of pain that will extend down the leg, over and around the knee, and may go as far as the foot. So again, sometimes what can happen is someone comes in, they're complaining of knee pain, and actually the problem is an underlying hip joint problem as well. So again, this needs to be cleared before we finally conclude where this source of pain is coming from. What are some of the current menus of conservative care out there? First line that we'll see for most people developing knee osteoarthritis pain are things such as NSAIDs or nonsteroidal anti-inflammatory drugs. These are very effective in reducing the inflammatory process in the knee. There are two types generally out there right now. There's what's called non-selective. These are most of the ones that you'll see right now, ibuprofen or Advil, naproxen, Aleve is also over the counter. There's also a group called the COX-2 inhibitors. Celebrex is the only one currently left on the market. These tend to have a lesser effect on stomach and GI problems. However, keep in mind, and this comes from an FDA consumer update in 2015, that all NSAIDs can create GI problems, stomach irritation, and go on to possibly things like GI bleeding, and also have an effect on cardiac issues as well. More so seen in the COX-2 inhibitors such as Celebrex, when a patient has an already strong history of heart disease or prior heart attack, there is an increased risk when taking these medications. So the thing to remember is generally you don't want to be taking these medications for long periods of time, and particularly taking them for long periods of time without having your physician know about this. Your physician should be aware that you're taking these medications, how long you're taking them, what dose levels, particularly if you have a history of GI problems or have a history of heart disease. Another thing that can be used to help with sort of the inflammatory changes in the knee, particularly when a person is having an acute inflammatory onset, are things like corticosteroid injections. They do benefit and sometimes allow the patient to get over that flare-up of their knee osteoarthritis and allow them to get back to more activity and start to get that joint moving and a little bit more healthy. The thing to remember here is this is only a short-term effect, generally 6 to 12 weeks in most of the literature. The other thing to remember is cortisone does not affect the disease process. It does not change the progression of the disease. The biggest things we'll see side effect-wise here, if somebody who has diabetes, there can be short-term elevated blood sugar levels following a corticosteroid injection. Just make sure the physician who's doing the injection is aware of your diabetes, and you may want to monitor your blood sugars a little more closely. And with any injection, there's always a very slight risk of infection. Another type of injection that people talk a lot about are the hyaluronic acid injections. I have patients tell me all the time, I just had a gel or a rooster, or some people call this a chicken shot. The reason they call it the rooster shot is the original formula was the protein that was isolated for this was taken from the comb of the rooster. And what happens is they're reintroducing this protein into the joint with hopes of giving some more health in regards to the environment of the joint for the hyaline cartilage, as well as helping to lubricate the joint a little bit more to allow a better freedom of motion and reduce inflammatory process. I listed on the side here, you'll see up to 8 of these hyaluronic acid formulas that are available. They typically run either a 1, a 3, or a 5-shot series. Every physician has sort of their one that they like to use. In the studies, there's mixed results. Some people either have a very good effect or some people have no effect at all. It does appear to be more effective in earlier to mid-stage osteoarthritis, not as great in late-stage osteoarthritis. And those who respond positively to the first injection usually are more likely to have benefits for follow-up injections. Injection series are usually spaced about 6 months apart. And there have been a few studies that show that you may delay the sort of going on to total knee replacement as much as 2 years with the use of a hyaluronic acid injection. Braces. Braces are a really nice, effective, and cheap way to reduce some of the pain and problems, particularly in mid-stage osteoarthritis. What we see here are people who are having difficulty with certain activities that they would like to do, say prolonged walking, playing maybe a light round of tennis or golf, or just wanting to be a little more active. Use of an unloading brace can sometimes give them enough pain relief to be able to do these activities again, as well as to do these activities with far less aggravation of their knee. So braces are an effective way to reduce some of the stress and load on the knee and allow people to become more functional, which in the end may allow them to move this joint more and strengthen the limb and the leg a little bit more. Again, either delaying or slowing some of the functional losses that we see associated with knee osteoarthritis. Another group of injectables that we see out there are biologics. Typically, the ones we see most common right now are PRP or plasma-rich protein or stem cell injections. Review of the literature shows current studies really do not support their use for knee OA. Stem cell is still in its infancy, and I would say maybe we're going to keep an eye on this over the next few years as they start to sort of tweak the genetics of the stem cells here a little bit. We may see a little bit more effect, but right now, really not seeing major effects with these injections. PRP, one study did show that PRP in conjunction with the hyaluronic acid or gel shots may have a slightly significant improvement in the sort of the result of that injection. Again, this was only in about, I think, 1 or 2 studies. And the problem here is we're not sure whether the cost of the PRP in conjunction with hyaluronic acid gives a significant enough change to make it worthwhile at this time. The other issue is that typically these injections are not covered by insurance and become a significant out-of-pocket expense for the patient. Exercise. Here's the one that really most people miss. Persons with knee OA who exercise to a mild level can expect reduction in both knee pain and disability from the duration of their intervention. And what they're saying here is people with knee OA can exercise, and exercise can markedly not only improve their function, but reduce their pain. The other thing to remember too, individuals without knee OA who continue to exercise do not show progression of their disease. Matter of fact, marathoners have a much lower level of knee osteoarthritis than non-marathoners. Again, this goes back to that talk we had a little bit earlier about sedentary lifestyles, and that showing that there's been a doubling of the prevalence of knee osteoarthritis since the mid-20th century. Exercise therapy, how effective is it? This was an interesting study done in 2013, and what it did is it compared exercise to other interventions. It looked both at function as well as pain. So the blue line here, or the blue bar, is pain. The yellow line is function. And so what it did is compare it to education, weight loss, paracetamol. Paracetamol is actually is Tylenol. It's the European term for Tylenol. And the NSAID that was studied here was ibuprofen, one of the sort of standard NSAIDs that we use frequently to control inflammation in the osteoarthritis. And I think the biggest shock they got out of this study was not only was exercise much more effective than all these other ways of treating the disease process, but the big shocker here was not only an improvement in function, but the pain reduction was actually better than the actual pain relievers. So exercise not only has an effect on the person's ability to function or do activities, but it can markedly reduce their pain better than the actual pain relievers. What should an exercise program include? It should include some type of aerobic exercise, whether that's walking, biking, hiking, swimming, something where we're actually incorporating sort of the cardiovascular system into the activity. Why? Healthier cardiovascular system means better blood perfusion and general better health for the system, as well as just joints being helped with better blood flow, better movement, better perfusion of materials for healthy joints. Quadriceps strengthening, we talked about this before. A healthy quadriceps can take away up to 70% of the force of the limb when the heel strikes the ground, both in walking and running. So people with good quadriceps strength markedly reduce the stress coming into the knee joint. So if somebody with moderate stage knee osteoarthritis who's having difficulties with prolonged walking, riding, biking, running, going upstairs, strengthening their quadriceps can reduce the shock levels going into the knee and reduce possibly the pain levels from that underlying osteoarthritis. So quadriceps strengthening, real important. Resistance training here, we're talking about not just the quadriceps, but the leg in general. And finally, neuromuscular retraining. What is that? What we tend to see here sometimes is when somebody has sustained a problem with a limb or a joint. For instance, they had a flare-up of the osteoarthritis, or they've had prior injury to the region. There's changes in how that body area moves and is perceived by the nervous system. So what happens is people start to move in an abnormal fashion. They may do things like keep their leg very stiff with activities. They may overflex their knee with certain activities. And this may increase the loading problems across the knee. So neuromuscular retraining is a way to sort of get that pattern broken, get that limb moving better, and again, reduce stress and strain across the joint. Quadriceps strengthening, there's all types of exercise we can do for this. Anything from just seated knee extensions to straight leg raises or modified squats. Hear all the time from people, oh, I was told I should never squat. Really not true. You might not be able to squat as deep. You may not be able to use heavy weights anymore for squats, but squats are a very, very important trainer for the knee, both in strength, but also functionally. Things like getting up from a chair or getting up from a toilet are a squat, and we need to make sure you have that capability. Resistance training can run anything from going to the gym and using sort of high-tech machines to simply getting an inexpensive cuff weight and doing just some simple knee exercises at home. It does not have to be complicated. Neuromuscular training is what we talked about before. There's all types of neuromuscular training. Basically, what we're talking about here is trying to sort of break bad habits and patterns, trying to get these hips and knees to move in a better way to reduce stress and strain across the area, as well improve things like moving, like balance, and decreasing risk of falls from the knee pain and weakness problems. Surgery for knee osteoarthritis. Sometimes, despite whatever we do, this disease will progress to a stage where people may start to consider things like surgical interventions. Up until several years ago, one of the things that we see a lot is arthroscopic debridement, or we would hear the surgeon tell a patient, we're going to go in and cut out your arthritis. Study after study in recent years is showing this is not a good procedure and is no longer recommended in the treatment of knee osteoarthritis. Again, keep in mind, this is different from meniscus surgery. Meniscus surgery sometimes can be very beneficial for certain groups of patients. The main thing to remember here is it's affecting the meniscus, not touching the hyaline cartilage, which is older surgery used to do. Another surgery that we rarely see anymore was what's called a tibial or femoral osteotomy, where they would actually break the bone of either the tibia or femur and realign it to sort of take pressure off a worn cartilage area. This was generally done for people younger than 60 years old with only one-sided knee disease. Kind of falling out of favor now because of other things that we can do for knee osteoarthritis, plus the advent of things like a partial or unicompartment knee replacement as well can buy time for these younger patients. Unicompartmental knee arthroplasty or replacement is where what happens, they just replace one side of the knee joint, usually reserved for younger patients. Again, it's sort of a bridging technique in that we have a 50-year-old patient, severe one side, say inside or medial compartment knee osteoarthritis. We can replace that area of the knee by this patient anywhere from 10, 15 years with this, and then convert it to a total knee replacement later in life. So they're not having to go through repeated knee replacements throughout their life. Looking at knee replacement, what we have here is on the left side of the screen, this is the unicompartmental, or you see where they just replace one area of the joint. And here's the actual total knee replacement as well. Here it looks like an x-ray. Knee replacement in end-stage osteoarthritis, which has failed all other conservative care, is an excellent way to restore function and reduce pain for many of these patients. So what's the take-home message? If you're active, stay active. You're not going to increase or progress your knee osteoarthritis by being active. If you're not active, it's time to get active. But remember, you've got to bring this back slow and steady. Things like non-steroidal anti-inflammatory drugs and cortisones can help control pain and inflammatory episodes. There are risk factors with both of these. Again, you want to make sure you're discussing this with your physician. Hyaluronic acid injections can help, and one study shows they can delay total knee replacement for up to 2 years. Unloading braces are a cost-effective way to manage particularly unilateral or either inside or outside knee osteoarthritis. Again, what they can help here is get someone who wants to maintain certain levels of activity to maintain those activity levels with less pain and discomfort. Biologics such as PRP or stem cells are really not currently supported in the literature. Again, I think stem cells possibly have a chance over the next couple of years, but we need to keep our eye in the literature. Surgery, arthroscopic debridement is no longer supported. People 55 or older with degenerative meniscal tears, there's a lot of question marks now whether this should go on to surgery or not. Traumatic tears more likely may need surgery. Exercise, early through mid-stage, is highly supported by studies. And remember that one study that we discussed earlier, not only does it improve function, but it actually relieves pain more than the pain relievers. Weight loss, yes, a resounding yes. Weight loss really does lower your risk of developing knee osteoarthritis, as well as some of the dietary issues like low vitamin D and adherence to Mediterranean diet are also showing that they can help or slow some of the progression of this disease. In end-stage disease, total replacement, it's a viable option to help and really get this person back and moving. And again, somebody who's really lost function over a long period of time starts to develop other health issues as well. So sometimes knee replacement might be required to get them up and moving and help their other health conditions as well. So we want to keep that in mind. And sometimes total knee replacement is the way to go. So we're finished for today. Any questions, you can contact us at our telephone number, 908-813-8200, or email listed below. We also have links on the page, as I said before, to 2 of the outcome forms that you can fill out to track your own condition as well as be able to email questions to us later on. Thank you. I hope everyone has a fabulous day.